And I think the second thing they taught me, and what I love about ketamine rewires the brain and the nervous system. So when we're looking, especially at first responders and military, just bringing awareness somatically is huge. And as we all know, a lot of them are under chronic stress, chronic fight or flight. And as you mentioned, Gail, that's taken a huge toll on their bodies.
This episode explores ketamine-assisted therapy and psychedelic-assisted treatments, including their emerging role in behavioral health, clinical applications, and considerations for integrated care.
Hello, welcome.
Thank you for having me.
It's so good to have our very special guest today, Dr. Jane Caplan. I'm going to talk a little bit more about you in a second, but just introduce myself as I'm Dr. Gayle Cordes. I'm the faculty with Cummings Graduate Institute for Behavioral Health Studies, and we have the good fortune to meet with Dr. Caplan today to talk about a very interesting and timely topic out there in the world in general, and certainly in healthcare. So I want to give everybody a little background on you, if that's okay, Dr. Caplan. You are a Harvard-educated psychiatrist who has come from, that's sort of a gold standard in medicine, come from that background, and now are working with some bold and what we might say, even a little disruptive, pioneering efforts in the mission of healing what we've traditionally referred to as more, mental health issues. But as we know, health, the the uh, the brain and the body are connected. So we're all about approaching, the healthcare from a whole mind and body perspective. And I know that that you are leading, very leading edge in that realm. So we're looking forward to hearing more from you about the work that you've done over these last few years as you've migrated into the CAP healing clinic that you have in Phoenix, Arizona, with ketamine-assisted psychotherapy, and that has proven to be significantly effective with particularly some of the more treatment-resisted, depression-related presentations. And I think you've worked with a number of physicians as well with case referrals in that realm. So I have some questions for you about that. And also, there's a lot of interest in this emerging research and opportunity as it relates to the psychedelic-assisted therapies as well. So I hope we can spend a little bit of time on that as well. And as far as your acronym for CAP, I have to say, I love it. Instead of chemical-assisted psychotherapy, your approach now as consciousness-assisted psychotherapy seems to be like right out there in front of things. So with that, can we dive right in to some questions?
Let's dive right in.
Okay. Feel free to call me Gail, and I may not always do Dr. Caplan if that's okay with you as well.
Yes, please.
Okay. But we are so blessed to have you with us to share your wisdom from this very important part of the healing world. So I guess if we start with kind of what drew you to the ketamine-assisted psychotherapy treatment and as well the psychedelic medicines, and how your perspective has evolved and developed and changed over the course of your practice, because you've been practicing for a long time, right? So if we can start with that, that'd be great, Jane.
Okay. Yeah, as you mentioned, I did train at Harvard, and I did my adult training there, followed by child and adolescent. And we were really trained as a psychiatrist to do both the medication management and psychotherapy. So I had been doing that with very, resourced, high functioning people for 18 or 20 years, and just kind of providing the gold standard of care. And I had certain patients that should have been getting better, and they just weren't. and I was doing everything right and by the book and in a very traditional and historical model. And then I also had a few patients with very severe trauma that did seem to defy the textbook.
Mhm.
And I just wanted to understand more about what was going on. And I felt I needed to start educating myself. So I went to a ketamine-assisted psychotherapy conference in California over a weekend, and it was one of the first that was being run. And it was just a bunch of clinicians in California talking about some of their work with the oral ketamine troche. And I was blown away. So I came home and did a deep dive into, okay, what could this look like? And that really changed the course of my entire career.
Okay. Okay. So that and that would have been circa like what year?
That was 2018.
2018. Okay. So you've been at this this new branch, this new focus for 8 years now. Yeah.
That's correct. Yes.
Okay.
Yes.
Okay. All right. Well, as if we kind of zoom in first on the ketamine, um, and then broaden our review into the psychedelics. If we start with just from a neurobiological, psychological perspective, with ketamine assisted therapy, what do you think is actually happening? What grabbed you 8 years ago as you sat with other clinicians learning about this particular strategy from a medication standpoint?
Yeah. So they were talking about breakthroughs that were possible on the ketamine that weren't possible in traditional talk therapy, psychotherapies, or even more advanced things like EMDR, and somatic work. So I called some longstanding patients of mine and I said, "Hey, do you want to try this oral ketamine troche with me?" And they were up for it. And many of them had been, even prior to me, had been in therapy for sometimes 10 years. Some of them had been in analytic work and they were just stuck. So what was fascinating is on the ketamine, they were noticeably more relaxed, better able to talk, and while the defenses still came up, better able to move through them. And I think what we understand from the neurobiological perspective that makes ketamine and the psychedelics so interesting is there's a suppression of the default mode network of the brain, which is where we hold our narratives about ourselves and the world around us. And sometimes those narratives, as we know from trauma or just from life, are subconscious, unconscious. And we know that that subconscious, unconscious drives a lot of our behavior, whether it's our thoughts or what's happening in our body. So when the ketamine creates a suppression of that default mode, all of a sudden other things start to open up and flow more freely. And the person suddenly has access to subconscious or unconscious material that they were trying hard to get to, but their defenses just would not allow it.
Oh, that so resonates. And I have seen that having been a long time practitioner of EMDR therapy and just listening to you talk about that workshop you went to that changed the trajectory of your practice. That certainly was the case for me, early in my years of psychotherapy, early around 2000 when I did the basic training in EMDR, and then for, years worked as a clinician, and with a lot of complex trauma. But you could see there were, I would be in awe of some of the breakthroughs that could occur. And I worked with a number of folks for a very long time. But exactly what you're describing, we would get to that place with some folks, and it was like, okay, even this power tool is not moving the needle. So this this makes so much sense to me. And that would be a place where a referral sounds like it would make good sense. And
Hmm.
for listeners who work in the behavioral health realm to understand
Hmm.
that. Okay.
Exactly. And we often see on the ketamine with that just shift in those neural networks that all the prior work the person has been doing on themselves, they are able to access that. So nothing is lost, and they're really able to sometimes integrate even further. And something that is often missed, I think, when we're talking about ketamine is, the route of administration and dosing. And as a physician, of course, that's something that I'm very tuned into, but
Mhm.
it really affects that suppression of the default mode. So when we do the oral ketamine, which is just 20% bioavailable, or we do IV ketamine, which is 99% bioavailable, and then there's dosing ranges in between that really affects that suppression of the default mode. So in, say, a psychotherapy, if you're wanting to do EMDR with ketamine, or IFS with ketamine, or somatic work with ketamine, you really want the person very much present and just a slight alteration of that non-ordinary state of consciousness, which would be very light dosing. On the other end of the spectrum, though, when we really squash that default mode, that's where you see that ego disintegration, and the person really goes into a very deep, non-ordinary state, connects sort of metaphysically. You're not really doing therapy, but there are benefits to that. And I think as clinicians, something we really need to think about is what form of ketamine are we using, what dosing, and why? What is our why behind what
Mhm.
we're doing?
Mm, that sounds very key. Now, I want to go back to a little bit of the language that you use to clarify. Just um, can you explain a little bit about what the oral would be the troche? Is that correct?
Yes.
So, can you explain a little bit for our listeners what's a troche versus the IV, which is more like 90% of the oomph or the power of the ketamine, and what exactly is that, and how is that obtained and all that. I mean, through a medical provider. If you could
Yes.
talk a little bit about that.
Sure. And there are actually four different routes of administration of the ketamine. So the oral troche is, and they're all prescribed by a physician, and someone really does need to undergo a thorough medical eval to make sure that they are a candidate for ketamine. And we can talk about who's not a candidate and what that eval looks like. But the oral ketamine is a troche, and a compounding pharmacy will create those based on the person's weight. So the dosing is pretty consistent across patients. As long as you're dosing it according to their weight, you're going to get a very similar effect. So that consistency is really nice for clinicians.
Okay.
And the person really self-administers that troche because it is prescribed specifically to them. So they just place it under the tongue, it dissolves, and then in about 10 minutes, they can feel the ketamine in their system, and it'll last somewhere between 60 and 90 minutes. So it gives you a really great amount of time for a session.
Okay. Yeah.
And then
Yeah.
after that, there's also um, the intramuscular ketamine. Personally, I love the use of the intramuscular because with the IM, it just goes straight into the muscle. You can usually apply it right into the deltoid, so it's very easy. It's kind of like a flu shot. And the ketamine hits them a little bit faster and they go a little bit deeper, but you can also dose it at a range where people are perfectly able to do therapy. Or you can dose it a little higher, and then they have maybe 10, 20, 30, 40 minutes of more of that non-ordinary state, depending on what you're looking for. So the IM is really particularly good for people who have dissociative processes. And I'm not quite sure why that is, but we tend to really see the dissociation come out with the IM ketamine, and it's harder to see it so clearly with the oral or the IV. And then there is a nasal inhaled. That's Spravato. That's a drug company creation. They took the generic ketamine and did the mirror image of it. So it is a slightly different chemical structure. And unfortunately, I think with the nasal inhaled, it's very difficult to do therapy because it goes straight through the nose into the brain, and it's a pretty potent hit of ketamine. And I think people are feel a little bit more euphoria from that, and they're more groggy, and so they're less able to participate. But because it's a nasal inhaled, it hits fast and it's gone fast. So you probably have a 20, 30, maybe 40-minute effect from that. And unfortunately, I had worked with a couple of people on the nasal inhaled, and I thought, why did the drug company make it this way? It's impossible to use. And then I thought, yeah, I mean, we do know that substances that are nasal inhaled do tend to be quite addictive
Mm,
because you get that hit to the brain. And while on the one hand, you could say, well, it's nice that the ketamine is getting to the brain for the neural rewiring, we also have to wonder about the level of addiction that can occur with the nasal inhaled, especially if people,
okay.
are just kind of sitting in a doctor's office in a chair or doing it at home watching TV. We're not getting a lot of therapeutic effect there.
Right. Oh, very important points. So
Yeah,
this probably ties then nicely into um, the questions I have about integration of, how ketamine assisted psychotherapy, the and integrating the benefits of that. So based on what you're just saying about the Spravato, that would be a concern. It's sort of like it's a nice, you feel nice for a while and then it goes away and you can't really, there's not really any treatment benefit post administration of that, and potentially a downside risk of, oh, I want to do that again and again. Am I getting that?
exactly. Yeah,
Okay.
exactly. And I think greater reliance on the drug for the
Okay.
shifts in mood that you're seeing.
Okay.
Yeah. And with more dependence on the drug, of course, we know that there's going to be more tolerance. And so then sometimes people need additional dosing or higher doses to achieve the same effect.
Okay.
And we do see that with the IV too. I think the IV, you are getting the greatest drug effect. And so for people who are very depressed, and needing the neuroplasticity of new neuronal connections because they've been in such a depressive state, I mean, the IV is really quite amazing for that. And you see rapid, neuroplastic changes. But again, Gail, what you brought up around integration is so important because on the IV, people go so far into a non-ordinary state. Sometimes it's difficult for them to bring that material back. And when they do bring it back for integration, what's been interesting to observe is now they're back in an ordinary state. So when you're in an ordinary state, it's hard to hold a
Mm-hmm.
non-ordinary state. And that's a part of what we talk about with integration is how do we help people remember and hold the material from those non-ordinary states, and then how do they bring them in? And I think that it's another important, thing to note around dosing and route of administration, because when we're on the oral ketamine or a light dose IM, integration is sort of happening as they're on the drug.
Mm-hmm.
So we're working on those neuroplastic shifts and our therapeutic interventions on the drug, and we're shifting as we walk through. When we're on higher doses, more drug, more non-ordinary state, we're having to do that integration, more of that work later. So, there's no right or wrong, but again, just kind of thinking about what we're doing with each type, I think is really important for future clinicians to be thinking about and working on, and what are the most effective ways that we can work with these substances at those different dosing ranges.
Makes a lot of sense. So I know you have done a lot of work with us, I would say a special population that is relevant to a lot of our listeners as well. So first responders, vets, and so forth. That and the larger population certainly can be affected as well by complex post-traumatic stress disorder and those presentations. So, general population with elevated ACE scores and so forth. So, we see a lot of more complex presentations. And from as you think about the work that you've done and what you've witnessed, and maybe we shift a little from the ketamine into the broader spectrum of some of um, the psychedelics. Um, what are, you know, what are you kind of concluding from that experience, and how has that potentially changed your approach and practice with this type of a presentation? Because from an integrated care standpoint, the medical utilization from patients dealing with complex PTSD, those who, whether it's first responders and vets, or those who have lived with um, horrific adversity in childhood for a variety of reasons, that are uh, it's how do we get better outcomes for these patients, kind of that quintuple aim thing, across the system, the medical cost offset, the improved life, and everything in between on that spectrum. So I know I'm throwing out a whole lot here at you, Jane, but if you maybe just as we segue from just ketamine to some of these others and this population and the amazing work that you've done, with some of those folks. I'd be really interested. I think our listeners would be very interested in hearing with you and this kind of pioneer in this realm, what your thoughts are about this and what the potential is that you see and that you're pursuing, I know, in your work. So,
Yeah, no, it's a great question. And the first part of my answer may or may not surprise the clinicians. I'm not sure. But I think what I am very grateful for that this population has taught me is when you're working with them, it comes back to us.
mhm,
And what I mean by that is we have to think of the clinician. And in my training at least, we spent so much time thinking about the patient and their diagnoses and their presentation and their history. And yes, at Harvard, we all were required to be in therapy and we had supervision about our countertransferential reactions. But I think what I learned on the ketamine with these populations that fascinated me is the neurobiological synchronicity that starts to happen in the room between clinician and patient when the patient is on a psychedelic or ketamine. And I think there's something that happens with both the mirror neurons and the nervous system where the person opens and they become very sensitive to you. They become very sensitive to the environment, the setting, and that really includes the clinician. So I noticed that it was really important for me in ketamine sessions, especially with people with deep trauma. I needed to come in with a nervous system that was regulated. And if I did that, I could regulate them very quickly.
mhm,
But if my nervous system was off, our sessions weren't as good. And I also needed to come in a more meditative state. So I had to clear my mind. There was no thinking about, the grocery list or what I was doing later that afternoon. And a certain amount of just pure presence was a key to their healing. So my clarity directly affected the quality of their session. So that was the first thing that they really taught me. And I think the second thing they taught me, and what I love about ketamine rewires the brain and the nervous system. So when we're looking, especially at first responders and military, just bringing awareness somatically is huge. And as we all know, a lot of them are under chronic stress, chronic fight or flight. And as you mentioned, Gayle, that's taken a huge toll on their bodies and their medical symptoms. And so with the ketamine, the body also opens up, and there is the ability for clinicians to really guide and help people tune into, okay, what is happening in the body? Where am I holding my stress? Where am I holding my tension? What are the patterns that I put my body through? And how do I start to interrupt some of those fight or flight patterns
mhm,
or the cycling of fight or flight, freeze, shut down, collapse, and kind of helping people come back into that ventral vagal mode.
Mhm.
there's so much opportunity on the ketamine to do that. So I think that's in the relationship with the clinician, in the somatic work. And I kind of call it climbing, up and down this ladder. So we're working with the clinician, we're working with the body. Now we can kind of move into the memory reconsolidation, the parts work, and then some of the existential meaning making pieces that are necessary. So that's kind of how I see it. And, I think it's worth just noting that as I've trained clinicians in the ketamine, they have also noticed that, hey, have you ever felt like when the client's on the ketamine, I'm feeling like almost a ketamine reverberation? And
Mm.
there is something about that syncing up that
Mhm.
happens,
Mhm.
um, that that the clinician becomes very aware that the non-ordinary state is very different. And the clinician starts to also lose a little bit of you're holding your book knowledge and you're holding what you know about IFS or EMDR or polyvagal, but you're also the ability to move into a more intuitive state is very, very helpful in that process.
Okay. So this is so interesting. And as you were talking, I was thinking of Porges's work in the social model of the polyvagal system. It's sort of like this is like what you just described is like it's all there. I mean, it's all there from and we think about the ramifications of trauma symptomology and that contraction and that isolation. And so it's sort of like all it's almost magical how this is just opening up the opportunity to reconnect, to sort of resolve that
Mhm.
disconnect and withdrawal that happens. Um,
Exactly. And where we thought in the past, hey, it could take years due to what we know with attachment theory for someone to work through CPTSD, complex trauma.
mhm,
It's like, no, actually, we can form a relationship and alliance very quickly when someone is on the ketamine because they can feel our safety. They can feel our nervous system. They can intuitively connect in relationship in ways that probably have not been available to people since early childhood. But that also is such a reminder to the clinicians that these are
responsibility.
really sacred spaces, and we need to prepare ourselves and bring ourselves properly into those spaces.
Wow. Yeah, in any therapeutic interaction, recognizing you're an emotional regulator is important, but it seems, paramount in this interaction,
Hmm.
that opening that you're accomplishing
Hmm.
with the medication. So,
Hmm.
what are your thoughts on the psychedelic side, Dr. Kaplan? I mean, when it comes to we hear about psilocybin and we hear about ibogaine, we hear about MDMA, all of these, and yeah, I know Johns Hopkins isn't it? Johns Hopkins is doing quite a bit of work with, is that? Are they doing that around? There's psilocybin, I think, but it's obviously these are still in terms of classification. These are not medicines or that are available, at least in the US market. There are restrictions around this. But internationally, I know there's also work going on. What's your take on all of that? What wisdom would you impart, to a behavioral health provider, and the knowledge, like what are key points to know about this that you have learned and can pass on, in and making sense of it all? Like,
I
is this
know.
a
I think
bad thing? Is this a good thing? Is it like most things somewhere in between? How do we find the middle way?
exactly. I think how do we find the middle way that you just framed the entire question?
Okay.
Because that is the core. It's such a exciting and transformative time. And, there's so many drugs that are in phase 3 trials, LSD, psilocybin, DMT, and these are really powerful heavy hitters in terms of the brain, and they're heavy hitters in terms of their origins as plant medicines and as powerful tools that have been used in indigenous communities for a long time. And I think that really points to what's the middle way? How do we actually understand, deeply understand how indigenous have used non-traditional healing methods very effectively, where the Western world has kind of gotten in our box. And it's not a bad box, but when we're only living in that box, we're missing so many opportunities. So in the indigenous way, as you pointed out at the beginning, the mind and the body are not separate, and they really are treated and seen as one. And these medicines open the brain and the body into a connectivity that is just not available in an ordinary state of mind. So what do we do? And how do we train clinicians? And how do we even start to understand when that neural connectivity between the brain and the autonomic nervous system starts to really open? What do we do with that? Because the opportunities are truly endless. But if we're missing it, what are we potentially shutting down? Not just missing, but where are we potentially rewiring in ways that could be harmful because our awareness is lacking. And I think that's where we have a lot to learn from Indigenous communities.
Okay.
What are your thoughts about that?
Oh, I could not agree more. I had an amazing trip to Peru the end of last year and in the high Andes and um, just observing the culture. And obviously, they're near the Amazon. They have access to all sorts of psychedelic plants and such. So, but there's a certain peace in the population that I was gifted to interface with that I thought we've lost this in the Western world, in our certainly in our part of the world. And um, so it was really, really impactful. Now, can we specifically, I think you've had some experience with the iboga, well, that's the plant, but ibogaine. Um, can I sort of volley this back to you to share maybe some specifics around who who can be helped by that, um, and why, and
Mhm,
what are the responsibilities around that,
mhm.
from a from an ethical and standpoint and all that sort of thing.
Yeah, well, we're really seeing our underserved populations like military and first responders who are not being helped with our purely Western model. They're really seeking these alternative treatments and they're sort of leading the charge to say, we need more. And within those populations, though, there is a lot of mixed feelings about the psychedelics.
Mm.
And particularly in the military. So on the one hand, we have veterans committing suicide at unprecedented rates. But on the other, they're going down to Mexico where ibogaine, iboga are legal to seek help, to seek relief, but they're getting it in this sort of quick fix. And as we know, the quick fix can create mixed results.
Kind of what we were talking about earlier with um, even the administration of the ketamine without a therapeutic component, the IM or the Spavada or whatever, and without a therapy, it's so that's the
It's a very
significant.
hit or miss.
Yeah.
Yeah, so I think they're desperate and so they're going down. And I have been working with, in particular, elite special operators who have been Green Berets, Navy SEALs, Army Rangers, even Israeli forces. And they've had significant trauma over the years going for treatment with ibogaine. And I will say this, what is fascinating about ibogaine is it originates in Africa with the iboga root. And it was shown to me that it is one of the most powerful psychedelics because of its deep interaction with us at a primal level.
Mm.
And it's sort of interesting because if you think about it, a root we all supposedly originated in Africa. And
Mhm.
so potentially this root does interact with us at a deep level. And everyone who undergoes the treatment says that the root or the ibogaine, which is a synthetic, and it's the most powerful alkaloid out of the iboga root. So ibogaine is a very powerful substance, but it shows you where in the brain it's rewiring and where it's fixing. And it's a 12-hour psychedelic experience. And people come out of it, and especially special operators who've had significant traumatic brain injury report a great amount of relief. And I'm treating someone now who, you know, he was constantly getting concussions week after week after week in Afghanistan. And he did ibogaine because he was going to kill himself.
Mhm.
And he had a very spiritual awakening experience. And now he's going back to school to become a therapist.
Ah,
And it's amazing because even after multiple concussions and traumatic brain injury, the ibogaine has not completely fixed it, but he's in a master's program, not on stimulant medications, and he's getting all A's. So I think that says something about what's happening with the ibogaine. And on top of that, people who have opiate addiction issues, after one dose of ibogaine, they do not have cravings for opiate medications for 6 months. It's
well, this is compelling.
very compelling. It's very
Yeah.
compelling. So I think there is so much, but right now, while it is legal in Mexico, the way that it's being done is really a giant drug dose with almost no integration. And essentially, what's happening is people are given this drug, their brains are opening, the neuroplasticity is fueled. But then what happens with that neuroplasticity is really just left to the person to figure out. And that's where I think, clinicians, we've got to take over this and not let it be solely in the hands of drug companies. Or I think, in its historical context, people didn't have trauma like they do now. So we really have to take this on and do the interventions that we know are going to help people rewire in all the ways that we want them to.
So great opportunity for this in the next 10 to 15, 20 years may change dramatically. But how it changes is what's important, and our role is an important one in that. That's what I'm hearing.
Yes.
Yeah.
That's how I feel. Yes. And I know that sometimes, you know, the the transformative effects and the potential, it's easy to get overly excited about any one drug. And if I've learned one thing over the last 8 years, it's less about the drug and it's more about how we as clinicians are going to use them.
Well put. So behavioral health providers are integral across the healthcare spectrum. I've thought about that so much, as we think about working shoulder to shoulder with medical providers and what, you know, our understanding of ACE scores, of trauma, developmental, all of this, like this is not being taught in medical school. And the neurobiology of all of this is so strategically important. So as I'm listening to you wrap that up, it's sort of like, yes, and this is why we matter and what we do matters, and continuing to be out there on the frontiers, as even a little disruptive now and then, but in order to influence how these particular medicines can be used in not just through the wisdom of the indigenous, we can learn from that, but more responsibly in our communities and in our states and in our countries, as the case may be. So
Exactly. And
the work
the
will grow.
hopeful part is the nervous system can change and the brain can change. And we have the ability to change our brains and our bodies toward greater health. And the sooner that clinicians really understand these medicines and then are able to communicate that to the general public about what works and what doesn't work and why. I think the more responsibly we're going to be able to hold these medicines in the ways that they're meant to be used for the greater good.
Right.
And without that, I think there's a huge potential for destructive use. People on these medicines are very open, they're very vulnerable. Um, I think the person sitting across has to be incredibly responsible, incredibly ethical, incredibly compassionate and caring, incredibly open to change and innovation. So I think we have with what is the phrase with, great opportunity comes great responsibility.
Amen.
And I
Yes.
think that,
Yeah.
that really lands on us.
Yeah. 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 One of the other things as we're having this conversation that really lands for me is uh, it's not, this isn't a just shortcut, skip everything else, all the other modality, whatever. It's sort of when you have engaged, and I certainly am a fan of leading edge trauma therapy. So I think we have limitations with, not that I'm not dissing cognitive behavioral therapy at all, it has its place. But when it comes certainly to trauma, and what we know about the brain now, it has its limitations. So as we look at all these, modalities that have emerged, as we've talked about today, the somatic therapies, IFS, EMDR, and so forth, that those can be very efficient solutions for many things related to trauma presentations. It's when you've got this deep level and developmental kind of trauma complex presentation that even with you're talking about your elite military folks, so many folks have gone into the military to build a life and to get away from something. So we know, coming back to those developmental years, that on many of those cases that you've got um, both going on. So when you don't necessarily go straight to ketamine-assisted psychotherapy or straight to any of the more experimental psychedelics, it's that, and I loved how you said earlier that those, even when you do get to that, the benefits gained from the earlier work are simply enhanced, if I understood you correctly. So it's not lost,
Mhm,
but enhanced.
mhm,
So that's another kind of takeaway I'm extrapolating from our conversation. Does that ring true for you?
mhm.
Okay.
Absolutely, absolutely. And
Okay.
as we know, the other thing I love about the Ibogaine is with the military, they often go back to childhood. And the Ibogaine takes people through something they refer to as the life review. And how the medicine knows how to do that is beyond me, but it finds the areas of unprocessed traumatic material or emotional dysregulation, and it takes people through that. And so most of them do end up going back surprisingly to their childhood, and they don't end up talking about any of their military trauma.
Well,
So
I can
as we
certainly
know, that kind of makes sense, doesn't it?
in my own work and EMDR with a lot of complex presentations with vets, that would be it wasn't the war of their adult life, it was the war they survived as a child that oftentimes became the target memories that were needed to be reprocessed. So it's interesting you mentioned that because that
Yeah.
very much came true for me in my anecdotally in my own clinical work.
Mhm.
And I know we need to wrap up, and I'm so grateful for your time. But one thing, as you were talking about the greater good a moment ago, um, one of the things that can be so heart-wrenching for us is access. And some of these things are available if you have resources. But we have such a in terms of the greater good, we have so many folks that have limited resources, in adverse situations, even currently, and so forth. And how to get access is and anything, because I know your heart's there too, Dr. Kaplan. That's one piece, and the other piece, just want to make sure we have address. I'm hoping that our listeners will be able to discern, but just in wrapping up, what to watch out for. And if you're in a position where you think a referral for this kind of treatment, let's just say ketamine right now, is appropriate. What quick and dirty advice can you give on look for this and don't refer here? And maybe it's not the self-administered by yourself at home kind of thing. I'm sure that's pretty obvious. Those couple of things would be really helpful. Just a couple of thoughts on, are there any ways that folks without a lot of resources can access ketamine-assisted psychotherapy, or certain, in the US, for example, certain states where there may be, I know we're having funding issues with a lot of Medicaid and all that. But those two pieces we didn't get to today. So any quick thoughts on that as we prepare to wrap up?
I know. I think that's the tension between the drug companies monetizing plant medicine. And on the one hand, the drug company does create safety and efficacy and a better pharmacological understanding of these plants. But it also becomes monetized, and then people who are waiting and needing care, they have to wait until this all goes through private pay and then insurance based, and then finally down to Medicare, Medicaid. And that can take years. And on the other hand of the debate is, hey, these are plants that we once used that grow freely on the earth, and this should be legal, and anyone should be able to access a plant when they want. But then it's like, well, society is a little more complicated than it used to be. And
Mhm.
what happens when people start dosing psychedelics alone or in communities that aren't safe? That can lead to a lot of problems. So I think as a society, these are the big issues that we have to face and talk about and educate one another and really try to be as thoughtful as possible for our communities and one another. Um, and I was thinking one thing that I would be remiss in not talking about, that I forgot to mention earlier, is that as we talk about clinicians and our amazing understanding of the brain and the nervous system and interventions, there is something that happens with these medicines that's much more difficult to calculate or get our hands around, and that is the metaphysical experiences that people often have. And those metaphysical experiences, which could be a past life or a connection with a loved one or an ability to see into the future or the sense of
Mm.
oneness with humanity, all of these very unexpected things can come up with some clients and not with others. And the way that I learned to hold space for that was I thought about how Freud used dream interpretation, and
Mhm.
anything that's coming out of the psyche is something to be held. And Carl Jung did this as well with the sense of this collective unconscious. And what is consciousness itself is a question that gets raised. Does
Yeah.
consciousness originate from our brain, or is consciousness outside of the brain?
Mhm.
And how does consciousness develop differently than the brain does?
Mhm.
So I think I would have been remiss in not, and I think for clinicians to
Yeah.
kind of open their minds to what are those metaphysical experiences and how do we best hold space for them, knowing that, maybe we can't catalog or categorize them, but they are certainly important in healing.
Yes. Oh, I couldn't agree more.
Yeah, sorry, I had to just
No,
say that because I think
wow.
that's an important part of the discussion.
Very important in consciousness-assisted psychotherapy.
Yeah.
Dear,
But
I
I
love
would say,
yes.
yeah, but to answer the last part of your question, when you're thinking about referring someone, if someone is looking potentially for deeper trauma work, we don't want someone who has a history of psychosis. We don't want someone who is currently bipolar and unmedicated. If they're bipolar and they're well managed, ketamine is a great option to help their mood and their trauma. And I have found that people who have borderline personality do not do well in the ketamine work. It's very disruptive to their identity. And I've seen it actually worsen people who have severe borderline. But on the other hand, people who have more of a narcissistic constellation do exceptionally well. And I think it's because once you get past the fragility of the defense and you can really support them through, they can really move through some material quite quickly. So that was an interesting, yeah, that was interesting for me to see. And I would say, when you're looking for a clinic or a place to refer, you want to make sure that they do offer some support, guidance, therapeutic intervention. There's a lot of clinics that are kind of churn and burn. So we want to avoid the churn and burn where there's a lot of drug and very little support.
Right, right. I know. I've seen a number of facilities open that were anesthesiologists, and a receptionist. It's sort of like,
Yeah,
not that. That
yeah,
wouldn't be recommended. Okay, got it.
exactly.
Okay, okay. Well, Jane, I can't tell you how grateful I am for you sharing your knowledge and your wisdom with my audience from an educational standpoint. I've learned more today, and I've also been lifted up just by the interaction. So I know that our viewers will benefit from this. So thank you for your giving of your time and your wisdom and your knowledge. And
Mhm,
if folks are interested in training in this,
mhm,
I believe you offering some
mhm.
trainings now
About
for clinicians?
Yeah, about every 6 weeks, I'll do a Friday, Saturday, Sunday training in the ketamine-assisted psychotherapy. And our Friday is really a trauma protocol that's very somatic and neurobiologically based. And so that's day one.
Okay.
And then day two is more of the energetic, indigenous, metaphysical, consciousness-based work. How do we understand these things slightly differently? And then day three is our experiential, where people have the opportunity in pairs to use the oral ketamine on one another and go through the protocol. And then
Okay.
we'll do the IM so people can experience that more non-ordinary state. And we do all of that on Sunday. So it's a lot in 3 days, but it's really fun. And so if anyone's interested, you can contact the clinic, 602-324-4622, and we can let you know when the trainings are.
Okay. Can you repeat that phone number, please?
Yeah, sure. So it's 602-324-4622.
And that will take them to Cap Healing.
Yes.
And is it Where Psych and Cap Healing? Those are, and you have a website as well, right?
Yeah, so my kind of aware psych is our typical med management, therapy, somatic work, and we do peptides as well to help with the
Yeah,
regulation of the
we
nervous
wanted to get that
system,
in. Yes.
inflammation.
We may
So
have
that's
to
sort of
have
our,
another conversation about peptides in the future.
I know, I
Yeah.
really think they're part of the future too. So that's kind of the Aware Psych brand. And then the CAP Healing is the consciousness assisted psychotherapy with ketamine. But we're in the same office. It just kind of branded it differently.
Okay, fantastic. Well, I'll make sure that we have that information in the notes for our talk today as well, in
Thank you.
case folks want more information about that. But
Thank you so much for having me today. And thank you to everyone who's interested in this work and moving the field forward so that we can innovate and, elevate the level of mental health care available to people who, are really struggling and needing our help.
well, back at you.
Okay.
Thank you so
Thank
much.
you, Gail.
So stay well, and look forward to speaking again with you sometime soon.
Okay.
Okay, take care,
Thank
Jay.
you. You too.
Bye bye.
Okay. Bye.
If you enjoyed this episode, don't forget to subscribe and share. Let's keep disrupting healthcare together. Until next time.